Cleanse prostate. So the prostate is an exocrine gland surrounding the urethra in males. Its origin from the urinary bladder. What is the function of the prostate? The male. What is the purpose of the prostate gland in the male? Why should it be there? Any idea?
Something to do with seminal fluid, sir.
Something. Seminal fluid. Seminal fluid is a separate thing from the seminal vesicle.
It produces some fluid that nourishes the sperm, sir.
Very good. The average weight is only 11 to 16 grams.
Yes, sir.
Secretes a milky white alkaline fluid which contributes 30% of the volume of the semen, helps in the survival of spermatozoa. So that is a very important function.
Yes, sir.
Majority of male infertility cases may be related to this inadequate functioning of the prostate gland. So the volume is given by that alkalinity is very important for the survival of the spermatozoa. Otherwise, they will die off before they could reach the core. It is considerable amount of smooth muscle which helps in ejaculation of the semen. So the ejaculation of the semen occurs because of the smooth muscles in the prostate gland. So these are the two important functions in the adult male that is done by the prostate gland. Now, anatomy is situated here. And how many lobes of the prostate are there?
5 lobes, sir.
5 lobes. What are the 5 lobes?
Median, anterior, 2 lateral, sir.
Very good. Anterior, posterior, and 2 lateral.
2 lateral.
You have 2 laterals. You have the anterior lobe. There is 1 posterior lobe and 1 median lobe. Which one commonly enlarges? The BHP. And
median and the lateral.
Median and lateral.
Lobes. Very good. So what are all the histological zones of prostate gland? Describe that. How many histological zones are there in the prostate gland? And what is the importance of
4, sir.
Very good.
McNeil zones. Central, peripheral, central, peripheral, anterior, and transitional, sir.
Peripheral, central, transitional, and
anterior.
Muscular fiber. So the peripheral zone composes of 70% of the subcapsular and posterior aspect of distal urethra. This is the site mainly for cancer prostate arises in this peripheral zone.
Yes,
there is a central zone which is about 25%, which surrounds the ejaculatory ducts, and 2.5% of the cancer prostate arises here and are more aggressive and infiltrate seminal vesicle also. The prostatic cancer arising from the central zone is much more aggressive and rapidly spreading. There is a transition zone from 5 to 8%. This is the zone which surrounds the proximal urethra, and the tissue here grows during the whole life. And this is the one responsible for benign hypertrophy of the prostate. So there is an anterior fibromuscular zone made up of muscle and fibrous tissue. So there are 4 physiological zones of the prostate gland which are responsible for the identification of CA prostate, peripheral zone more commonly, and also from central zone, BHP mainly from transitional zone, and anterior muscular zone. What is the definition? This is the picture which will give you a good idea about the 1968. He described that. This is the proximal urethra, which is surrounded by the transitional zone. Then there is the ejaculatory tract, which is surrounded by the central zone, the peripheral zone. This is the anterior fibromuscular zone. So all these things are involved in this. 4 zones are there. This is the 3-dimensional picture of how these zones are. So this is the seminal vesicle with the ejaculatory duct, combining and joining the urethra here. This is the fibromuscular zone. So that the transitional zone contains the proximal urethra arising from the bladder. Peripheral zone is surrounding all the 3. So the whole orientation is there. So this is what they described in the various forms. What is the exact definition of BHP? How will you define BHP? Or benign hypertrophy of the prostate? Definition for that?
Benign enlargement of the prostate.
It is a non-cancerous growth of the prostatic tissue, especially at the proximal area of the urethra, causing compression and resistance to urine outflow. That is the definition. So it's a benign condition. So you must say it is non-cancerous, and it is caused by the proliferation of the prostatic tissue, mainly around the proximal urethra, resulting in compression of the urethra and resistance to flow of urine. What is the mechanism? How is this? What is the pathophysiology? How does it happen? This pathophysiology knowledge is important because medical or conservative management is based on this particular knowledge. What should we know about the pathophysiology? Why
Because of
all people-
stromal proliferation and agnosis.
how does it happen?
Periurethral transition.
Yeah, every man, all men have prostate, but not all men suffer from enlargement of the prostate. So, what is the pathophysiology to cause enlargement and problems only in a few unfortunate men? What is the hormone responsible for this growth and reduction or increase in size of the prostate?
Testosterone.
Testosterone, very good. So, will testosterone directly cause this problem, or will have to be converted into
Dihydrotestosterone.
converted into dihydrotestosterone? Okay. This picture will tell you the pathophysiology. Molecular control of prostate growth. In normal prostate, the dihydrotestosterone has got both agonistic and antagonistic properties, resulting in a correct balance of cell proliferation and cell death. So, normally the size of the prostate remains the same without enlargement. But in the persons where this agonistic activity causing cell proliferation is more compared to the antagonistic activity, which should cause the apoptosis or cell death, is reduced, then the prostate starts enlarging. Okay? So this is the basic mechanism. So that is why one of the drugs that is used to control the growth of the bladder, I mean prostate,
Finasteride. Finasteride.
anti-diastasis
inhibitor.
drugs. Okay, so we use that as a medical management based on this only. So this is the same picture how to show testosterone converted to dihydrotestosterone. There are testosterone receptors, and then growth factors are all stimulated. Whereas here there is an inhibition which is causing the cell death. Then proliferation happens, and this proliferation causes enlargement near the proximal urethra, shifting the urethra and preventing the easy flow of the urine. So there is an increased proliferation as well as angiogenesis. That is why sometimes what may be the first feature of enlarged prostate may be simple hematuria. Sometimes patients may not have any urinary symptoms at all, but they come for hematuria. So any adult male after the age of 40, he complains of hematuria, the urologist will always check for the size of the prostate. So the size of the prostate, the bleeding occurs because there is not only the increase in the transitional zone cells, but also angiogenesis happens, and there is decreased apoptosis of cell death, which results in prostate enlargement. And this can manifest in three forms. One is the bladder outlet obstruction, which causes difficulty in voiding. Then it can cause lower urinary tract symptoms like distended bladder, increased pressure on the backflow of the ureters, often heteroureter, even heteronephrosis. All these things can happen. Or patient may come suddenly with an acute urinary retention, as it might have been the case that we are discussing today, the polycatheter, that the patient may have come with an acute retention. Now, blood supply to the prostate gland is from the internal ilia branches from inferior vesical artery, middle rectal and internal pudendal. These are the three branches of internal iliac which supply the blood supply. And venous drainage means from prostatic plexus, which all drain into internal iliac vein. So internal iliac artery is the arterial supply, and internal iliac vein is the venous drainage. This is the nervous. You have sympathetic, you have parasympathetic, and you have the pudendal nerve sacral ganglia, which are all responsible for the control of the bladder. Now, coming to the physiology of micturition, what I told you, the brain, spinal cord, and peripheral ganglia all affect the micturition reflex. So, afferent pathways from the bladder to the brain include the dorsal system and the spinothalamic tract. So, the control goes up to that. Different pathways from the brain to the bladder exist for nutrition and storage, requiring the bladder an outlet, which is in the form of bladder neck, etc. The sympathetic fibers arising from T11 to L2, they travel in the hypogastric nerve. They link to the base of the bladder and urethra. And there are two types of receptors, beta 3 adrenergic receptors. Normally, we talk about beta 1 and beta 2. Beta 1 is cardio-chronotropy, and beta 2 is bronchodilation. The beta 3 is here. Where else is beta 3 operating? The subfamily of beta adrenergic receptor, beta 1 and beta 2 are mainly at the cardiovascular system and the bronchial tree. Beta 2 against cause bronchodilation. Beta 3, what action is here? Huh?
Adipocytes, sir, white
Adipose
and brown
tissue,
adipocytes.
excellent, fat, yes, excellent, fat lysis. So beta 3 is also responsible for lipolysis. And alpha 1 is the adrenergic receptor, which is a smooth muscle relaxant. So
Yes, sir.
this is how the storage occurs. It relaxes the bladder and causes the urethra to contract. And parasympathetic ganglion arise from the S2 to S4. They are mainly muscarinic, M3 receptor, muscarinic receptors traveling in the pelvic nerves to the bladder. And somatic nerves, in the form of pudendal nerves, again S2 to S4, they control the external urethral sphincter. So, sympathetic for storage, parasympathetic S2 to S4, 3 muscarinic receptors for retrosal contraction and evacuation. And the outlet is controlled by the pudendal nerve external urethral sphincter. So all the three are involved. So when the sympathetic postganglion neurons release noradrenaline, the beta 3 receptors are stimulated to relax the bladder smooth muscle, while the alpha 2 receptors are stimulated to contract the smooth muscles of the urine. So this secondary action, this alpha receptor blocker, is used again for conservative management of prostate for urinary symptoms. We see shortly what are the drugs that we are going to use. So parasympathetic postganglionic axons release acetylcholine. The 3 receptors are stimulated, which cause the retrosal contraction for voiding. At the same time, urethral sphincter, external urethral sphincter also will be relaxed. This is the pathways that conjunctively lead to urination. Cortical center, we have the second frontal gyrus in the paracentral lobule, which is inhibitory to the pons. This is the control with which we are able to hold the urine. Even if you are feeling the fullness of bladder, we are able to hold it till we reach the restroom. That is because of this cortical center control. But the brainstem control is mainly in the pons, which is called the Barrington nucleus, which is facilitatory to micturition. Sacral spinal is called the on-off nucleus, which is parasympathetic, especially for evacuation. So these are the 3 controls which are there in the nervous system. Stimulatory pathway for storage and for voiding. So for storage, we have to stimulate the hypogastric nerve to relax the bladder and constrict the internal urethra, proximal urethra. For feeling, for voiding, you have to stimulate the pelvic nerve, that is the parasympathetic and pudendal nerves. So if you understand that much, it is more than enough. The definition, as I told earlier, is a non-cancerous increase in the size of the prostate gland, which involves hyperplasia of prostatic stromal and epithelial cells, resulting in the formation of large, barely discrete nodules in the transitional zone. So this is the zone where BHP occurs. Other areas, if they are enlarging, it will be mostly cancerous. So it will not be a benign hypertrophy at all, which push on and narrow the urethra, resulting in increased resistance to the flow of urine from the gland. Now, the main cause is the dihydrosterone alteration. So, if it is overacting, then you will have a excessive growth. But what are the risk factors? The cause is dihydrosterone excess. But what is the risk factors are aging. So many after the age of 40, 1/3 of the men experience moderate to severe symptoms. By age of 60, half also by 1/3 by 60 and more than half by age of 80. And if there is a family history of blood relative father or brother having the prostate problem, it is likely to be there in those family also. The ethnic background, Asians are more common than white and black men. Diabetes and heart diseases also show an increased risk, and the obesity is another important risk factor for BHP. And exercise can lower your risk. What are the clinical features of BHP? American Neurological Association symptoms. Patient may have the following during urination: hesitancy or hematuria, or incomplete sense of voiding. Stream becomes progressively thinner. Frequency, urgency, non-pedia, and dribbling. So you can remember this by the mnemonic his fund. It's having a fund because of this problem. The other types which can happen are acute urinary retention or recurrent UTIs, fatigue, anorexia. All these things also may be cause for BHP. The presentation of BHP. Nausea, vomiting, pelvic discomfort, pain, azotemia, renal failure, and blood in the urine, especially hematuria, first time occurring, you always test for prostate. And the treatment sometimes may be acute retention, immediate catheterization may be required, or a suprapubic cystostomy also may be needed if you are not able to pass a catheter. Otherwise, you can do a watchful waiting for monitor the disease progression in milder cases. Another important point you remember is some patients develop hernia or hemorrhoids due to straining to pass urine. They come with the main complaint of these problems. So they may not know that they are having this problem secondary to the straining of urine. So proper questioning only will relieve. So they will come with saying that I have a bulge in my lower abdomen, right side, left side, or I'm passing blood along with my motion every day. But if you test them, you may have a large prostate, which is cause the secondary problems of hernia. So this is how a suprapubic cystostomy is done. First, you can put a needle and aspirate clear urine. Then you can use a trocar. Then for everything we use ultrasound. So you can use an ultrasound to pass the trocar. And use a Seldinger technique like this. The bladder you first identify, pass a guide wire, then put a dilator or a trocar through that pass catheter, and you can put a Foley's catheter through this, and this is how the final picture looks. So it's an emergency management. Everyone has to know. Medical management of BHP. So initially, small size glands with not much of severe cochlear obstruction features. You try medical management. You relax the smooth muscles. I told you alpha-1 receptor is there for the urethra to constrict and relax. So you block that alpha-1 receptor blockers. Non-selective phenoxybenzoin is there, but we don't commonly use that. But with this phenoxybenzoin, where do we use it? It's an alpha-1 type receptor blocker.
Pheochromocytoma.
Excellent, excellent. So pheochromocytoma, you are supposed to first start this and then start the beta blocker. Whereas even though the same action is here, we don't use it commonly for TRP patients, I mean BHP patients. And then there are selective alpha-1 short-acting drugs like prazosin, alfusin, and epinephrine. So it comes as minipress XL. This is being used even to treat hypertension. So patients who are not hypertensive may also be using this. So if they are using that, you have to make sure that it doesn't cause severe hypertension on the table. So this XL may be used, which is prazosin. It's available as 2.5 milligram tablets also. And there is a second variety, third variety called long-acting prazosin, doxazosin, and alfusin. So it is available in the brand name Hydrin. It's also available in 5 milligram and 2 milligram strains. And lastly, it is a partial subtype inhibitor. It is not a pure alpha-1 inhibitor, but a partial subtype, which is tamsulosin, which is the drug which has been given to our case patient today. And that is available as Urimax 0.4 milligrams. And it's a combination of Urimax and
Dutastride.
Dutastride is there. So there are two preparations that are available. Then the second variety of drugs we use is what is called the Nadalafil. Is available as 5 milligram tablets, which is actually a phosphodiesterase inhibitor 5-NZ. There are several subfamilies of phosphodiesterase. So what is even peripherin and aminophylline? They are also phosphodiesterase inhibitors. But which category? They are 5 or
non-selective, sir.
phosphodiesterase 2 inhibitors. Okay, because the peripherin and aminophylline are phosphodiesterase 2. What about milrinone? Is also a phosphodiesterase, that is phosphodiesterase 3. Okay. So then there is a sildenafil. When will you use sildenafil? The patient with PHP.
Erectile dysfunction.
Erectile dysfunction. Diabetes patient with erectile dysfunction and PHP, this will be a good drug because it will take care of the erectile dysfunction at the same time it will reduce the prostate stage also. So in a non-erectile dysfunction patient, you use Nadalafil, but patient with DM and erectile dysfunction and PHP, you use this drug, sildenafil. And the third category is 5-alpha reductase type 2 inhibitor, which are finasteride and dutastride. This drug blocks the conversion of testosterone to dihydral testosterone. That is the reason why we should know that the method which is causing increase, resulting in decreased prostatic dihydral testosterone, which will inhibit the growth of the prostate. So, in early cases, this drug may work well because it will prevent the further increase of the size of the prostate. So, it is available as 5 milligram tablet finast and also as 1 milligram tablet, and it is also available in combination. The dutastride is also available with a combination of which is another partial, just like tamsulosin, this is another partial alpha-1 inhibitor. So this combination works out very well than the usual below. When do you advise surgery for VHP? That is, there are two indications. When the medical management fails, you put the patient on these drugs for 2-3 months or even 6 months. Patient is not having any much relief, then you have to go for surgery. Or if there are severe symptoms like acute retention and the need for catheterization, and this catheterization producing recurrent UTIs and all these things, then you decide about surgery. The older method was to go for open prostatectomy, which is very rarely done now. The current accepted method is TURP with receptoscope. The instrument that we use is called a receptoscope, which is minimally invasive. And there are newer techniques like transurethral needle ablation and transurethral microwave thermotherapy, which are all very minimally invasive methods. And more recently, they have introduced laser surgery like Foley laser ablation of prostate. What is the advantage of using this laser?
Minimizes bleeding, sir. Hemorrhage is minimal.
So what is the advantage? You can use it in even patients who are on anticoagulants.
Anticoagulants.
Okay, so if there is an urgent need to do the surgery, it actually completely coagulates, does not shave off or cut the tissues like what you do in TURP. So it completely coagulates the entire tissue, they shrivel and fall off. That is the mechanism by which this laser works. So if the patient is in anticoagulation like Turp and you don't have time because he is having some bleeding problem or he is an urgent channel formation, then you can go for laser even in the presence of antiplatelet agents or anticoagulant agents. So you have to do a thorough history examination, and usually they do a rectal examination. And in the rectal examination, they can find out which lobe is regular, what is the consistency, whether it is firm and rubbery or whether it is hard like stone, and it can indicate malignancy. So by rectal examination is a very important method by the urologist to find out the status of the gland. And prostate specific antigen, which is the indicator or marker for prostatic cancer, has to be done in all patients who have 10 years of life expectancy or more. You have to do sometimes urodynamic studies or ureteroscopy or ultrasound, and you have to do all the blood studies. So this is the ultrasound probe that is introduced through the anus and rectum to identify the bladder contour and the size. So this is the ultrasound for post-void bladder. So you can see the volume given is 121.6 ml, which is quite high. Normal acceptable limit is less than 60. So anything more than that, up to 150, patient may be not very symptomatic. Beyond 150, we will definitely become very symptomatic. So 120 is another indication for surgery. So this is also that will be done. Anesthetic consideration, they are usually elderly men, multiple comorbidities and many medications may be there. These are the investigations we do. And then every system, cardiovascular, respiratory, CNS, musculoskeletal is very, very important. Degenerative changes in the vertebra as well as the joints will give you problem in both the spinal anesthesia and positioning of the patient. And the endocrine, there may be majority of them may be diabetic patients. So the decision whether to stop the oral hypoglycemic agents or to switch them on to insulin, all these things will be raising and the examiner may ask you. So what is your idea about oral hypoglycemic agents? Will you stop them or will you continue with them or you have to switch over to insulin?
Stop them. Switch over to insulin and
It must. Supposing he has a good control with say metformin and sulfonylureas. Will you stop it and switch over to insulin or will you continue with that and go ahead with the surgery?
stop it, sir.
Right. Which one you will stop? On the day of surgery, you will stop or you will stop it prior to surgery and switch over to insulin like you do for others?
On the day of surgery, sir.
Why?
24 hours before surgery.
See, when do you allow oral in these patients after TUR? Do you start them for 24 hours, 36 hours? Nowadays, we start oral as soon
Within
as the
6
spinal
hours.
fluid goes
Within
up.
6 hours.
We don't
Yes, sir.
wait, isn't it? So
Yes, sir.
patients who are under good control with your oral anti-hypoglycemic agents can be continuing on that except metformin. You stop metformin because it can produce
Lactic acidosis.
lactic acidosis.
Lactic acidosis.
Okay, so
Yes.
you don't continue metformin, stop it prior day. Sulfonylureas are long acting. So if the patient has the tendency to take the drug on the morning, don't give it on the day of surgery. Till the previous night you can give whatever dose you have been taking. So there is no need to convert to insulin for TURP surgery because oral will be started. Oral liquids as well as diet will be started very soon after the surgery. Only in cases where you cannot give oral medications, you have to go for insulin for sugar control. Otherwise, in all surgeries where oral can be resumed soon after surgery, you can continue with your oral medication and stop it on the day of surgery depending upon the population. Okay, so that is the guideline that you have to follow. And preoperative urinary infection should be clear. So you must get a sterile urine, especially if the patient is on catheterization for a long time. And antibiotic prophylaxis is important. So always be given before start of surgery. And blood grouping should be done. The reservation should be done. You need not bring the blood to the OT, but you must reserve and keep it ready. And if the gland is more than 40 grams, you must make sure the patient is not preoperatively anemic. So anemia should be ruled out. And if the patient is on these following drugs, beta blockers, you have to continue. AC inhibitors, you withhold. Bronchodilator, if the patient is a COPD, continue. Anti-diabetic medications, you continue. Stop warfarin. If he is on atrial fibrillation and is on warfarin, you have to stop that. Go for the parenteral anticoagulant. The technique of choice is regional, either subarachnoid. Subarachnoid is the most common because it's technically simple and the level of block can be easily managed by adjusting the volume, position, and the speed of injection, all these things. Then epidural, caudal, saddle, all that being done. You need a level up to T10 to prevent the discomfort caused by the bladder, not the pain by the resection. So the main reason for a block up to T10 is for preventing the bladder distension discomfort. And D9 dermatol level will elicit the capsular sign, pain on the perforation of the prostatic capsule. So if the prostatic capsule is pierced, not the bladder, then the pain will be perceived to the T9 also. So up to T10 is sufficient. And it is technically easy, dense motor blockade, no cycle sparing. If you use a fine gauge needle, lesser incidence of BDPH. These are the monitors we normally use: ECG, blood pressure, pulse oximetry, temperature. What's the medication of the patient, blood loss, electrolytes, ATCO2, DAs. And if you are going to general anesthesia, it is only for contraindicated cases where spinal should not be given. And for usually patients who cannot lie down for a long time. This is a very important preoperative assessment we have to make sure. But you must ask the patient, are you able to sleep flat in your bed over the night? He says, no, I sleep with 3 pillows or 4 pillows, or I keep sleeping sitting. Then it is possible to do the surgery for them with a regional technique. Or if you develops a cough during lying down, then you have to go for CA. You can use endotracheal intubation or a Prof LMA because lithotomy will increase the pressure and chances of regurgitation and aspiration are more. And dilutional hypernatremia may prolong the neuromuscular block and can be post-op caudal for pain relief. And very rarely you can do the surgery at relay. I read one case report long back where it is in a very morbidly sick patient needing TURP. What he has done is he has injected 20 ml after completely evacuating the bladder. Patient was on catheter. He removed all the urine, they instilled about 20 ml of 1% Lidocaine inside the bladder and clamped the bladder and left it for about 10 minutes and asked the surgeon to proceed. So it nicely anesthetized the entire mucosa and the surgeon again actually do a dissection and release the channel. That was another back. The intraoperative complications are hypotension, TURP syndrome, hemorrhage, perforation of both bladder and prostatic capsule, hypothermia, bacteria, sepsis, complications of positioning, erection. This is another important complication. Initially, sometimes after giving spinal, you find the penile enlargement. Sometimes it may hinder with the introduction of the receptor that may be caused. And lastly, glycine toxicity. These are the 9 complications. And the glycine toxicity is a major contributor both in the CNS and retina. That is one of the reasons for the blindness also. It causes nausea, headache, malaise, and visual disturbance, and also depresses the myocardium. And it acts on the NMDA receptor potentiating. Unlike your ketamine, which is an NMDA antagonist, this is an agonist of the NMDA, which paradoxically may precipitate encephalopathy and seizures. And magnesium may also be reduced by dilution, which exerts negative control on the NMDA receptor, so having membrane stabilizing effect. So magnesium therapy should be considered as a part of treatment for seizure in POR patients. For sulfate being the recommended drug for control of seizure. And liver and kidneys metabolize the glycine to oxidative deamination to glycoxylic acid and ammonia. Redistribution half-life is only 6 minutes, whereas the terminal half-life is about 40 minutes to several hours. Okay? So the initial redistribution will happen within 6 minutes. And the role of hyperammonemia due to fever is unclear, though it may be one of the causes for cerebral depression. And what is the treatment for that? Any idea?
Arginine.
Arginine.
Arginine increases the ammonia metabolic cycle, can give magnesium to have a negative control on NMDA, and vision will automatically return within 24 hours. So, what is the dose of arginine and what is arginine?
Plays an important role in ornithine cycle, sir. Conversion of ammonia to
More than
urea.
what is the important role of arginine? Essential role of arginine.
Nitric oxide.
Nitric oxide.
Nitric
synthesis.
oxide release.
Yes, very good. So nitric oxide synthesis is by arginine. Not so many other rules. So TRP syndrome, all the things we discussed, can occur between 15 minutes after the surgery is started up to 24 hours. So even in the post-operative period, you can have all the symptoms of that. And the features are mainly circulatory overload, intoxication, hyponatremia, hypoosmolality, hyperglycemia, and hyperosmolysis. These are all the features of syndrome. So if there is a water intoxication, you will have cerebral edema, somnolence, restlessness, pupil edema, dilated and non-reactive pupil, AGE6QPP. And the other features are nausea, vomiting, irritability, and pulmonary edema and seizures. The change correctly said by the student is 120, you will have confusion, hypotension, bradycardia, while QRS complex. 115, you will have cardiac depression, bradycardia, while QRS complex, and elevated ST. And 110, you will have ventricular tachycardia and fibrillation. So, depending upon the sodium level, you have to act quickly to correct this condition. In hyperglycemia, see not all the thing. Hyperammonemia, more than 500 millimoles blood level, if it goes, then you will have all the problems. And the main reason already, if there is arginine deficiency, this will be the major factor. And you can measure the absorbed fluid by preoperative sodium divided by postoperative sodium multiplied by ECF minus ECF. This is the formula that we can use. Other methods are volumetric fluid balance and the gravimetry. You can measure the rise in the body weight, CVP monitoring, breath ethanol measurement. So more study material or research method. So they used to add ethanol to the irrigating fluid and then measure the quantity of ethanol in the patient's breath. And they did the isotopes added on the that also. So again, the various symptoms, systems which can be affected by Turp syndrome: neurological, cardiovascular, respiratory, physiologic, renal, metabolic. All those symptoms are. This is important from theory point of view also, because they ask you the Turp syndrome features. So immediate termination of surgery is the first sign and symptom. That is the first one. For infusion, this is ventilation if required. Whereas you can say it is 100% oxygen. It at least send blood for electrolytes, especially sodium and coagulation profile. Start furosemide 20 milligram. If the patient is already on chronic diuretics, and 40 milligram. Based on the response to the first dose. Then hypertonic saline can be given, restricted to those who develop seizures and cardiac dysfunction. So if there is a seizure activity or arrhythmia, you have to pull and give it very cautiously. You can use a central line. Monitor potassium also. Potassium also may be hypopelvic, and usually changes will get resolved. So how to minimize the risk of TRP syndrome? Operation before surgery. Patient should be adequately hydrated. You have to write the electrolyte coagulation profile and limit the duration of surgery to 1 hour or less. And the height of the irrigation fluid should be less than 60 centimeters. Limit the extent of bladder distension. The surgeon should frequently evacuate the bladder without distending it too much. And careful surgical resection without exposing the venous sinuses. The rule of 60 you have to follow. Section time less than 6 minutes. Weight of the gland resected should be less than 60 grams. Height of the irrigating fluid is less than 60. Arterial blood gases, hemoglobin, and serum sodium are to be estimated. Correction of hyponatremia should be done by diuresis and slow administration of 3% or 5% hypotonic saline. And the rate of administration should be 0.5 milliequivalent per hour or 100 ml per hour. Roughly, this you should all remember. Correction should be only 100 ml per hour. And approximately 200 ml of hypersonic saline may be needed for correction of hyponatremia. But rapid administration can result in central pontine myelinolysis. And 2/3 of the hypertonic saline restores serum sodium and osmolality, while 1/3 redistributes water from cells to extracellular space, where it becomes available to diuretic treatment with furosemide. And the intravenous calcium also needed in acute cardiac disturbance during surgery. Seizures may be managed by diazepam, midazolam, barbiturate, dilantin, or muscle relaxant depending upon the severity in the intraoperative phase. And blood loss may be managed by administering packed red blood cells. And in case of DAC, fibrinogen 3 to 4 grams should be given intravenously, followed by heparin infusion 2000 bolus and then 500 units per hour. Fresh frozen plasma and platelets may be used depending upon the coagulation profile. And analysis with the TEG, propylestography, is very important. The ideal irrigating fluid. This is another common question in the examination. They ask you what are the features of ideal irrigation fluid. Should be transparent for good visibility for the surgeon, and it should be electrically non-conductive to prevent dispersion of the current. It should be isotonic, non-toxic. It should not cause hemolysis, and it should be sterile and inexpensive. And ultimately, there is no such fluid available. These are the comparisons of the various fluids. Earlier, they were using distilled water. Glycine 1.5 to 1.2 to 1.5% is used, and the osmolality is 200. Still, this is also hypoosmolar only, but compared to all that, it's better. Mannitol is 275, very close to our normal osmolality, but it will cause excess diuresis and volume overload. Sorbitol, hyperglycemic, so cause hyperglycemia. So among all these things, the commonly used solution is glycine. Complications with the glycine, the same toxicity of the normal level is 13 to 17 milligrams per liter. It can cause transient blindness. The hemolysis happens only when you use water. sterile water was used in the earlier days, so it will cause hypotonic fluids are absorbed. It will cause hemolysis, which will cause hemoglobinuriria and result in acute renal failure. It also will cause chillness, lumpiness, and chest tightness. These things will happen. So the treatment is diuresis and electrolyte correction. Bleeding sometimes difficult to quantify because of the dilution. So tachycardia and hypertension may be masked by the bradycardia and hypertension of overhydration. So this is the trick in that bleeding problem. So we will identify it very late. The rough estimate is 15 ml of blood loss will happen for every gram of prostate resected. So we can calculate the blood loss. Separate of the irrigating fluid multiplied by the volume of the irrigating fluid divided by the section before surgery. Or another method is separate before and separate after by separate before. This is one another formula. Multiply it with 0.07 and 1000, then you can calculate the blood loss. For volume absorption, you have to know the 3 of sodium. Divide it by post of sodium, multiply it with the volume of ECF and subtract the volume of ECF. That the total volume of fluid that has been absorbed can be calculated. The causes of increased bleeding may be overhydration, vasodilation because of the SAB and lithotomy, increased venous pressure in prostatic sphincters. The urokinase release from the prostatic tissue also causes activation of the plasminogen, resulting in plasmic fibrinolysis. Delayed postoperative using on this thing. So you can use tranexamic acid or thiamine acid. Bladder perforation is another problem. So it can happen as an intraperitoneal or extraperitoneal. So peritoneal will happen if it is a rupture of the bladder dome. Extraperitoneal if it is a rupture of the bladder neck. Symptoms: abdominal distension, rigidity, sweating will happen only in this type. If it will go for bradycardia and hypertension. Non-return of irrigating fluid, that is a very important sign to indicate that there is a perforation. So it may require extraperitoneal, if it's localized, especially with catheterization and antibiotic. Intraperitoneal, you have to do a surgical program. Hypothermia, all the causes have been said. Bacteremia, if there's already existing urinary infection, you have to be very, very watchful. Now, the newer techniques for transcervical resection of prostate. Earlier, it was monopolar TURP, where the electrode had only one projecting rod, and the patient used to act as the conductor. So they used to apply the electrode pad to the patient. And this is the picture of that monopolar type that means let's see only one clip is getting section. Then came the bipolar pattern or TURP electrode, where it became formed a loop, and then there is no need for any head plating or the pad to be applied to the patient. So that went in surgery and the section was done. This is how the loop looks like. Those who are not seen this bipolar loop. How the picture looks when the surgeon resects the whole thing. And came the laser TURP, this thin coagulation treatment zone of 1 to 7 millimeter. So it doesn't open up the tissues at all. Completely coagulates or burns the tissues that prevents bleeding and intravascular absorption of bladder irrigating fluid. So in contrast to monopolar and bipolar, which open prostatic veins, the thin coagulation seals them. So there is no opening like this. So this is what happens. You can see it touches the tissue. The whole tissue gets completely burnt out. As a result, bleeding and absorption of bladder irrigating fluid are minimized. So laser TRP can be used in patients who are on antibiotics. So this is patients for patients who are high risk. If you stop the antibiotic like clopidogrel or aspirin, then for the laser TRP. And you can use normal saline because it is not going to generate any current which will be dispersed. So you can use normal saline as an irrigating fluid. That is another advantage of that. So deactivation of automatic implanted implanted pacemakers are not required because again there is current disbursement of laser. So the three advantages of laser TRP, it can be used in anticoagulated patients without stopping the anticoagulant. It can be used, you can use normal saline for irrigation, which is almost isotonic, and you can use the procedure without any complication in patients with pacemaker or implantable ICDs. So this is how the whole thing looks like. So the laser beam is inserted and the laser goes off in way and it violates the tissues. Just a quick clue for all the junior students who have not had an opportunity so far to see how a prostate surgery is performed. I thought I will go through the steps. First, you give a spinal, either in the landing position, but preferred it will be sitting position, especially the elderly who don't have to bend down, and sitting makes it easier for both you as well as the patient. Try to go as low as possible and give a spinal. After spinal, it is the anatomy position that you have to give. Ideally, you should have all the head stoppings and then proper support. And then the third step is to drape the patient and expose the genitals. And the next step is to insert the dilacane jelly. So this is what is this part called? This portion of the packing. Idea? It's called the applicator. Okay, so you
Applicator,
remove the
yeah.
cap. The cap will have a sharp end with which you break open the seal and then thread this to the nozzle, and you can just insert this into the urethra and squeeze the whole tube to the urethra. So this is called the applicator. So many centers they will sterilize the whole set and then keep it in the nurse's trolley itself so that they can apply. So after application of the jelly, they usually clamp it for a few minutes to effect the acts and prevent the jelly from flowing out. Then they insert the resector scope, like after the application of some jelly. Then the next step is to go for, this is how the whole attachments look like. So this is the fluid irrigation, this is the light source connection, this is the eyepiece, all those things are there. Older days, surgeons used to go through the eyepiece only and resect the scope. But nowadays, we go for, and because I did not get a picture for this, what is the stake in this? Patient looks like a female patient. Okay, so this is not your. So this is for a female because this eyepiece viewing. I could not get any other picture. I just pasted it there. This is the modern way of doing with the video monitoring. So the surgeon need not strain and look down and break his neck. So you can watch the video monitor and then go that. What is this instrument called? And
Cystoscope attached.
system. It's called the elite bladder evacuator. So every time after they complete the resection in between, what will they do? They will attach this and then press the bulb and then they get back all the debris and blood, whatever is collected there, that will be collected in the glass thing. Okay, so there are twin glass with a side bulb, so they have to press the bulb and then evacuate it. So, elite evacuator, this is the step in the surgery. So after completion of the resection, I have to put this catheter. This is a three-way Foley catheter. You can see there are three ways compared to the two-way which we put two-way Foley catheter. And this is what is friend said that the silastic catheter. For long, you can keep it in the and once the catheter is fixed like this, then you inflate the balloon with 40 ml. This is the strapping that is done. You stress the catheter nicely and strap it to the thigh. Because this traction only prevents further bleeding. And the irrigation is started in the post-operative period. So the whole thing goes in and then collects. So there will be difficulty in watching the urinary output here. So you have to be very watchful to see that the patient, because the irrigation fluid will automatically mix with the urine and come out. So you have to be very watchful to make sure that the patient is neither hydrated nor dehydrated. Most of complications are hypothermia and hypotension, hemorrhage, and septicemia. PRP syndrome can occur in the post-operative period also. Bladder spasm is a very important problem. Not retention to blocking of the catheter, deep vein thrombosis, and operative cognitive impairment. And whenever you get a patient for this normal case scenario, you have an elderly male patient who may have the following comorbidities. They are diabetic on OHA or insulin, diabetes with hypertension and COPD, who are on antiplatelet and antibiotic. Or you may be a cardiomyopathy or a patient with congestive failure and low ileum. And he may have Parkinsonism with severe rigidity, or he may have recovered from a stroke. And a pacemaker inserted patient also may come for PRP surgery. And polyarthritis or previous joint surgery patients may come. There are some of the comorbidities which the patients may come to you. Coming to our case, the 70-year-old male patient. So it belongs to geriatric age group. So all the problems of geriatric anesthesia you should be aware of. And his BP is 180, 112. So he is a known hypertensive. So what is the duration and what any features of target organ dysfunctions are there? And patient on aspirin, clopidogrel, metoprolol, statin. So any history of previous acute coronary syndrome or MI. The patient has an indwelling catheter for 2 months and prostate size is 90. So check for any recurrent UTI, and you have to convince the patient with the need for stage surgery, not in a single sitting. And thorough pre-op evaluation and optimization of the serious and renal function, and decision regarding antiplatelet agents and adequate control of BP, urine culture, sensitivity to rule out any ongoing infection. So unless you get a general urine, you should not operate on these patients. And plan for newer techniques like roll-up and tuna. The patient has been on anticoagulant for a long time. And plan for HDU care. Nowadays, there's a tendency to operate and send the patient to the same day. It's being done as a daycare procedure because of the advancements in the technique and all the facilities. But these sort of patients, you have to hold them back. History of cardiac problem, other things. So you have to fix the presentation. Any questions, any doubts, any additions? Okay. There are no questions. What shall we do? 1 o'clock.
On these, on the same lines, probably we can say a few words about the. Sorry, sir, for a bad throat. We can say something about the hysteroscopy and resection on, like you have the septum resection, or you have hysteroscopic surgery, polypectomy, things like that. How it is slightly different from the TURP problems, and it's very. The rest of it is all very similar. But the thing is, in hysteroscopy, the organ itself is very tight, and so there's a lot of thick tissues inside. So it goes under a lot of pressure. So there is a chances of them having air embolism, and problems with the embolism is much more than with the TURP. So these are a few differences between a hysteroscope and a prostate surgery. The rest of the problems like lithotomy and other things and medical problems and everything else is the same. But also the absorption of the irrigating fluid is more with the when they do an hysteroscopy because it goes to the tubes, it goes into the peritoneum, and then actually they come for infertility treatment. And the tube is blocked, then the chance of pressure is high. The tube is good, then the chances of absorption is greater. So these are a few differences when you talk about anesthesia for hysteroscopy. So I thought since we are talking about TURP, so it's a similar situation when they come for hysteroscopy. So I thought we'll just finish it.
Ablation also was done using the same technique, you know.
Sir?
Endometrial ablation.
Yes, sir.
Instead of doing DUB, instead of doing hysterectomy, they were trying endometrial ablation by this technique long back. Same method of irrigating and then burning the endometrial tissues.
No, now they do it. That is gone, sir. But they do a lot of hysteroscopy nowadays.
Oh, yeah.
For any procedures, they do a lot of hysteroscopy and hysteroscopic surgery. Hysteroscopic resection of septum. Polyps,
Endometrial ablation surgery has become not very well.
Obsolete, and they don't do it anymore, sir. Yes.